All right, everybody. So here we are. We're going to talk about one of my favorite conditions ever, meniscus tears. You should be able to figure out a meniscus tear right away and then be able to get this person the right treatment or referral as needed. So a couple of key things for us to understand right here. Number one, tear or derangement of the fibrocartilaginous disc between the tibia and femoral condyles within the knee joint. 50% of compressive load of the knee, and it's key. 50% of compressive load of the knee goes through the meniscus, whereas 85% of the load is transmitted in flexion at 90 degrees. So as you flex your knee more, the meniscus becomes even more important for weight-bearing capacity. The other thing that I should point out is I have been doing cadaver dissections for over 20 years, and everybody wants to say the medial meniscus is C-shaped, the other meniscus is O-shaped. There is huge anatomical variation in the shape of menisci, I guess we'll say. So right here, I just drew them all the same to keep it nice and simple, but I've seen menisci that cover the entire joint surface where there's even a thin membrane right over top in between the femur and tibia. And I've seen menisci that are super small and just around the outside edge and everything in between. So as different as we are as humans standing and how we look in height and body shape, it's the same thing in the difference of the shape of the meniscus. So do not think that patient X has the same shape meniscus as patient Y. There is substantial variation in their actual shapes. The physiology of this is pretty clear, the pathophysiology. Injury occurs as a result from repetitive activities, typically, usually twisting in a younger patient. It's a twisting, lifting event is what you want to see. A planted twisting on the foot is where we typically see it. Older patients usually have this injury secondary to osteoarthritis. The knee has become unstable, it's slopping around a little bit, and that's where you see it. 75% of all tears involve the medial meniscus. And here are some different types of tears. You can have a longitudinal tear, an anterior horn tear, posterior horn tear. And I'm just going to plant the seed for this later on. This anterior horn tear would only show up more into extension type challenges. This posterior horn tear would only show up into more flexion of the knee type challenges. So you have to have that knee really flexed in to pick that up. Horizontal tears, bucket handle tears, flap tears. These are the ones that can fold over, lock in on themselves, and then the knee joint gets stuck in that position and person has to move around a little bit. Meniscus tears are fantastic. Incidence, relatively common, 61 per 100,000. I would suggest it's even higher than that in certain athletic patient populations, like your soccer players especially. Peak age, 30 to 40 years old typically. Females tend to be a little bit younger when they get it, way more common in men than women. What are your risk factors? Obesity, prior knee injury, and osteoarthritis. If you are overweight, that means that you are carrying more load, and every time you go and plant in on that meniscus, it increases the risk of you actually having that injury. So a couple of key things for us to get: high risk in athletes or activities of individuals who are doing long-term standing and loading on that tissue, right? Associated with ligament capsular. Parse, I'll just be like, you can hang out, do whatever you want. I got to record this for like another 5 minutes or something. Associated ligament injuries, 33% of all meniscus tears in adults are associated with an ACL injury, okay? 92% of meniscus tears in younger patients are also associated with ACL injuries. As that knee becomes unstable, that's when you see the meniscus is taking more force that it shouldn't be having to take as it slips and slides around a little bit. Meniscal cysts are there as well. In a lot of the tears, you would have to see those on MRI or on ultrasound. Yeah. So a couple of key things to get as I continue this recording. We can go ahead and stretch out and be quiet in the background. That would be great. All right. So assessment, you can hang out. It's all good, Liam, but yeah. All right. So history, joint line tenderness following the twisting event. And this is the dead giveaway. The person literally, here I am in my professional attire, they're going to go like this and say, it hurts right here. And they're going to follow that joint line to show you the tenderness. Okay. Swelling is usually delayed. It will come on later if there is more damage inside. Degenerative tears often manifest with recurrent effusion. So what happens is it'll go away for a while, then it'll come back. Just due to inflammation of the synovial membranes around the joint capsule itself. Mechanism of injury may include single trauma or multiple repetitive events, especially if they do a deeper squat. As I told you earlier, we see more loading on the posterior part of the meniscus. When you get into that deeper squat, it may also predispose for this injury. So inspection, you are looking for an antalgic gait, local swelling and redness, maybe in 50% of the cases. They have to be pretty lean before you'll actually see the redness there, or pretty significant injury. A lot of people have a lot of extra soft tissue around there, and so you won't see that. But again, the palpation, you can palpate it. It is the joint line tenderness. Indicates 77 to 86% of patients with meniscus tears. So please know how to palpate a knee joint. Firm lump felt over the joint line may be a meniscal cyst. That would be more of a chronic case is where you would see that. Active and passive range of motion may be within normal limits, but may also be painful when you are at end ranges or compressing the damaged tissue. Pain or swelling, limited range of motion is common. Resistant range of motion may be weak due to pain if it results in more compression. And if it's a long-standing condition, you might see muscle atrophy as well from lack of use. Neurovascular screens should be within normal limits. DDX, because they are going to be predisposed to it later on, is going to be DJD or osteoarthritis of the knee. Osteochondritis dissecans can really look like this, except that when the knee locks, it'll lock in multiple different positions as that joint mouse, that little fragment of cartilage is all the way on one side of the joint, then on another side, all the way through there. Patellofemoral syndromes could be there. You always have to rule out ACL, MCL, LCL, PCL injuries at the same time. And there could also be iliotibial band syndromes. Okay, testing is key on this. You want to go from least invasive to most invasive. So generally starting with Apley's compression and distraction is okay. McMurray's is not a bad choice, pretty good in the literature. Thialci's test or the disco test is my go-to on this one. And when somebody does this, you have to watch and make sure, because when this is positive, they will often buckle or drop. And I should have said that about the meniscus tear as well. In the history, they might actually have the knee locks in place, or the knee feels like it just gives way and buckles and drops. Well, the disco test, as you're doing it, you can watch the video on it that we have on our website here. You're twisting the knee down into flexion. And as you work your way down, that's loading more of the meniscus on the posterior side. And if they get to that tear and it's significant enough, they will literally drop to the floor. So make sure they're on a table to be supported or have chairs around them or something like that. All right. What else are you going to do? Gold standard for imaging is going to be MRI. Healthy menisci look nice and black all the way through, low signal density. A torn meniscus will show you a fluid density in between, but be aware there is a poor correlation to how much tearing you see on imaging and how much pain the patient experiences. So don't make that judgment in their mind and say, wow, I'm surprised you can even walk. It just winds up putting false information to their brains that they don't need to hear. There's good research that talks about if I read you a radiology report as a patient and you don't understand it, it results in worsening of your symptoms. And I don't want to do that. All right. What do we see? 89% accuracy with MRIs. When you do that, clinical exam is as accurate as your MRIs. Okay. Yeah. This is what I should say. This is from Molnar et al. So it's basically saying 89% accuracy with MRIs and 89% accuracy with your physical exam. And I say this all the time in class, your physical exams are as good as the imaging. Don't be that doctor who can't do anything without imaging. A good physical exam is often going to be way more therapeutic for that patient as well. X-rays, not really warranted in these cases unless you're trying to rule out a fracture or you're trying to look at the level of osteoarthritis, but typically not going to be your best imaging choice. Arthroscopy might be okay if you're looking for the meniscus tear and really want to visualize it, 99% sensitivity and specificity, but again, may not necessarily be warranted. In fact, the British Medical Journal, we'll talk about this article here in a second. General measures. Number one, biopsychosocial support. You want to make sure that this person has the counseling and the recognition to understand that this condition may not be a career-ending injury. For a lot of people to think, oh, meniscus tear, I'm not going to be able to do X, Y, and Z. Nope, there's lots that you can still do and maintain a relatively normal life or normal biomechanical function. So short-term, consider use of crutches or steroids, and then steroids, okay, of braces, what I'm trying to say. I'm got to the severe injuries right here. Pain-free quadriceps exercises would be an excellent idea. Same thing with hamstrings. If you could do that in a pool, avoiding those deep squats, because we know biomechanically, as I get deeper into the movement, I'm going to be loading that meniscus a little bit more. Eventually, you'll want to progress to it as their tolerance builds up. Massage is going to be a great first choice to build up neurotolerance, local stimulation in the area. K-taping, I'm a big fan of instrument-assisted techniques. Anything you can do to promote motion and decrease swelling in the area, decrease pain. Osseous mobs and manip, usually not directly on the knee, but generally areas of compensation can offer benefits. So ankles and low back will all be good. Electrotherapies, medications would be a good choice as well for short-term use of NSAIDs maybe. And in more chronic cases that aren't showing results from other conservative management, you might consider prolotherapy injection type stuff as well. And in severe cases, the research is controversial, but arthroscopic meniscectomy may be warranted. However, I rarely ever quote an article directly like this, but this is from the British Medical Journal Guideline for Arthroscopy, and they say in nearly all patients with meniscus tears or osteoarthritis, arthroscopic surgery is not warranted. And they have strong recommendations against this for degenerative changes in the knee from multiple systematic reviews. And in fact, it is so significant, the authors even say further research is unlikely to alter this recommendation. So that means we've got this figured out. We know that our conservative management after 5 years, after 10 years, is going to result in the same, if not better outcomes than the surgical management. So why not treat it conservatively? And then here's your reference from right there that you can go ahead and look at. So as part of that conservative management, what are you going to be looking at? You're going to be looking at rehab programs that work on minimizing effusion, normalizing gait and passive range of motion, trying to limit muscle atrophy if possible, working on lower impact, non-impact workouts. That'll be like stationary bikes, get them in a pool if you can, or a hot tub. Also consider wobble boards. I'm a huge fan of wobble boards for meniscus and proprioceptive retraining. Evaluate and work towards exercise-specific activities. And the prognosis, smaller tears in the outer portion of the meniscus that has better vascularization, those heal way better. I talked about it right here, versus the inner zone, those tend to heal a little bit worse and take longer. Meniscus tears associated with instability, however, because you will be ruling out other knee injuries, have a lower prognosis. And basically that's what we have to get through. As long as they have a stable knee, they're going to see a better prognosis. Usually if the knee is unstable, it's going to take them longer to heal, if they can heal at all. And they might have an increased risk of osteoarthritis as well. Exercise rehab is key. What do we need to do? Educate our people first, empower them for movement, get them through some basic exercises, and then we can get in there with our manual therapies. And here I give you some examples of some exercises. Even just simple, non-weighted internal and external rotation of the tibia is not a bad idea. Simple banding exercises, working towards lunges, working towards squats eventually as you progress and see on an individualized basis what each patient can tolerate. So that's a quick run through meniscus tears. Hopefully you found that useful. I'll thank you very much for your time, and we'll see you on the next video. Bye-bye.